Hello there, what's up? Thanks for joining. My name is Dr. Rajiv. This is your education channel, YouTube Surgery and Orthopedic Education. In this lesson, we shall cover 10 MCQs on an important topic from competitive exams point of view, the vermiform appendix. Each MCQ will be followed by a description. You may prepare a note of important points for future reference. A lot of material would be delivered in this talk, so hang on in till the end. The correct answer in question number 1 is option B. The diagnosis of acute appendicitis is essentially clinical. It relies on the clinical examination of the abdomen. History, laboratory investigation, and imaging add in the diagnosis rather than exclude it. The cardinal features are right lower quadrant guarding and rebound tenderness, increased abdominal pain with cupping or movement, rigid abdomen, and involuntary guarding. In a minority of patients with acute appendicitis, some other signs may be noted. However, their absence never should be used to rule out appendicitis. These are pointing sign, Robson's sign, Schwarz sign, and obturator sign. The grey Turner sign indicates severe acute pancreatitis and leaking abdominal aortic aneurysm. In it, there is frank skin discoloration due to retroperitoneal hemorrhage. The correct answer in question number 2 is option D. The differential diagnosis of acute appendicitis in adult females includes but not limited to Mittelsmurg, pelvic inflammatory disease, pyelonephritis, ectopic pregnancy, torsion or rupture of ovarian cyst, and endometriosis. The mesenteric adenitis is a differential diagnosis in children. Other differential diagnoses in children are gastroenteritis, Mucus diverticulitis, intersusception, Henochus conlan purpura, and lobar pneumonia. The correct answer in question number 3 is option A. Differential diagnosis of acute appendicitis in elderly includes diverticulitis, intestinal obstruction, colonic carcinoma, torsion of appendix epiploicy, mesenteric infarction, and leaking aortic aneurysm. The correct answer in question number 4 is option A. Early antibiotic therapy in patients of acute appendicitis does not prevent appendicular rupture. Appendicular rupture is more common in extremes of ages. Fecolith may be an initiating factor for acute appendicitis. It also predisposes patients to appendicular rupture. Rupture should be suspected in the presence of generalized peritonitis and a strong inflammatory response. Appendicular rupture requires exploratory laparotomy, thorough washout, and appendectomy. The correct answer in question number 5 is option D. Bastido sign is an obsolete sign of chronic appendicitis. It involves dilating the colon with air, which causes acute right lower abdominal pain over McBurney's point. McBurney's sign is characterized by tenderness at McBurney's point. This point is typically the most tender area in cases of acute appendicitis. When pressure is applied to McBurney's point, patients with appendicitis often experience significant pain, which can help in diagnosing the condition. A Rowan sign is a clinical indicator associated with appendicitis. It is characterized by referred pain felt in the epigastrium when continuous firm pressure is applied over McBurney's point. But its diagnostic efficacy is not well established. Battle sign is also known as mastoid ecchymosis. It is a clinical indicator of a fracture of the middle cranial fossa of the skull. This sign manifests as bruising over the mastoid process. It typically appears 1 or 2 days after the initial trauma. Battle sign can be accompanied by other symptoms such as raccoon sign or bruising around the eyes, clear fluid drainage from the ears or nose, headaches, dizziness, and fatigue. The correct answers in question number 6 are options D and E. Purgation or the use of laxatives is not recommended in patients of acute appendicitis. Purgation can increase intra-abdominal pressure and may lead to the rupture of an inflamed cecum or appendix. Enema in any form is also not recommended during the treatment of acute appendicitis. It can be harmful. This also increases intra-abdominal pressure and may cause the rupture of an inflamed cecum or appendix. Historically, barium enemas were sometimes used diagnostically to identify appendicitis by showing a non-filling appendix. But this practice has now been replaced by more accurate and safer imaging techniques such as ultrasound and CT scans. The standard treatment for acute appendicitis is administration of IV fluids, analgesics, and antibiotics to reduce pain, infection, and inflammation, followed by an appendectomy. The correct answer in question number 8 is option A. Embryologically, the appendix is a mid-gut organ. It is first identified at 8 weeks of gestation as a small outpouching of the cecum. Since it is a mid-gut organ, the blood supply of the appendix is derived from the superior mesenteric artery. The correct answer in question number 9 is option C. The risk factors for rupture or perforation of the appendix are delay in seeking treatment, extremes of ages, male gender, compromised immune system such as steroid abuse, and comorbid conditions such as diabetes. Trauma in itself is not a cause. The correct answer in question number 10 is option D. The presence of air under the diaphragm on an X-ray, also known as pneumoperitoneum, can indicate several conditions. A perforated hollow viscus is the most common cause and includes conditions like perforated peptic ulcers, perforated typhoid ulcer. Air introduced during the abdominal surgery can remain in the peritoneal cavity for about 10 days. Blunt or penetrating trauma to the abdomen can cause bowel perforation and subsequent pneumoperitoneum. Conditions like necrotizing enterocolitis, especially in neonates, can lead to air under the diaphragm. Procedures like colonoscopy or peritoneal dialysis can introduce air into the peritoneal cavity. High pressure ventilation can sometimes cause air to escape into the peritoneal cavity.